think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
What complicates that question, though, is if you don't use, let's say, for example, subjective symptoms like headaches and tinnitus, if you don't use them in the evaluation of TBI, then you can compensate the veteran separately. So if the veteran's headaches, for example, are in a pattern analogous to migraine and warrant perhaps a 30% evaluation, you may assign the initial TBI evaluation under 80-35 and then assign a separate 30% for the headache because you didn't use it in the evaluation of the cognitive impairment. Sounds a little complex, doesn't it?
Yeah. Well, you know, yeah. You get to talking about the VA, it all becomes very complex unless you're dealing with it every day, you know, and you're up to date on everything and the changes they make and what have you. But the normal veteran certainly is in a world of hurt. They need some expertise, proper expertise going in facing the VA. Because like you say, sometimes it takes other people to, from observing you, to say, hey, this guy here, he's making claims on the wrong thing. This looks like something else to me.
Yeah.
And I can understand that happening.
Yeah, and you know that's not exclusive to TBI, although the topic tonight is TBI. But Dr. Bash and I worked together on many cases for several years with multiple sclerosis. And patients would have alternative diagnoses for symptoms that manifested during service or shortly thereafter. And only someone with the appropriate knowledge would, and motivation, obviously, would look at this in retrospect and say, hey, wait a minute, this started back here in the service records. I see it, you know? And so it's important to have good medical evidence, and it's important to have a motivated and sincere representative helping you. And particularly folks with TBI and emotional disorders that aren't always able to act in their own best interests. The impairment might impede their ability to express their claim, and that's always been troubling.
Well, yeah, sometimes it's hard to recognize these issues.
Jump in. Dr. Bash, what kind of medical test is required to diagnose a TBI?
Oh, the manual, the specific testing is not defined, okay? I'll leave it to Dr. Bash to describe what manifestations he looks for to make the diagnosis. The manual requires that for adjudication purposes, a diagnosis must be made by a physiatrist, psychiatrist, a neurosurgeon, or neurologist. And a general clinician can evaluate TBI, but only if they have completed VA's training module on TBI, and only if the diagnosis is already a record made by one of those specialists. And so the VA has imposed some little more stringent standards on who can conduct the exams and opine and things like that, which is probably a good thing.
Dr. Bash is a neuro-radiologist. It's probably some type of injury they can use to actually, show the brain. And because there's always, you've got to have some kind of evidence left over, be the white matter or something showing a brain injury. Because anytime you have an injury like that, basically it's like a concussion. Your brain will slap one side of your head, and it has to leave a scar somewhere.
Yeah, it's Bash. Yeah, we're neuroradiologists, the orphan children. There's only a couple thousand of us, versus 20,000 neurologists. So when they wrote that, they should have included us because there's some obvious things we can see on imaging that help with that. But it's a complicated thing, neurologists, and psychiatrists, and physiatrists, and neurosurgeons. Sometimes it takes the whole group to sort out what exactly is going on.
Well, at any rate, it takes a lot of research to nail it all down, because if you have a TBI injury and it's not showing any lesions and what have you, that seems like a real tough case to me. That how on earth are you going to prove that up? But Bill, give us some ways that can be proven up, and
sometimes it's a diagnosis of exclusion too, where you rule out, like Bill says, MS, you rule out brain tumor, and you rule out toxic exposures. Then you hear this history of trauma, the symptoms fit, and so you make a diagnosis that way.
Well, that's true. But there should be a way to measure it. I don't know. Would it take a test of some sort? Maybe. I don't know.
No, the
brain.
Go ahead.
Brain's the most complicated thing we know. We don't understand exactly, so we're kind of looking from the outside in. We have some neuropsych testing. We have rapid movement testing, eye movement, brain scan. There's a lot of stuff we can do, but there's nothing that tells us exactly in every case that this is going to be black and white TBI. So it's, a lot of medicine's in a gray zone. And they get the diagnosis wrong. Like this patient we're talking about, they gave him a diagnosis of amnesia, which was one symptom of his bigger, more global TBI problem. Later on, down the road, the medical record worked it out, gave him a more correct diagnosis.
Hey, Dr. Bash, what does the TBI situation have to do, say, if you have a head injury? I know back in the 90s, they didn't call it TBI. They called it basically a residual concussion when they did the rent schedule back then. But today, you see a lot of veterans have had neck injury or head injury and TBIs, and they have nerve damage in their ears and tinnitus. What's the link between those two?
Well, historically, medicine's known about TBIs for a long time. It's just that the Congress and the lay population is trying to catch up. We have all new imaging now, so it becomes kind of a term that people recognize. And the brain has its own set of functions, and it has all these nerves that run out and run different parts of the body. So, one place that happens a lot is in the temporal bone of the ear. There's 7th and 8th nerves that go through that ear, and oftentimes people have a fracture through the temporal bone, and it'll sever or traumatize those nerves to the 7th and 8th ear function. That's where you get the dizziness and loss of function. So that's a common thing. The skull and the brain kind of have a dance going on, and if the skull gets hurt in a certain way, the brain is going to respond. And if the skull fractures in a certain way, there's certain common places it fractures, kind of concrete. It's not poured correctly, it's going to crack in a certain place. So the brain has some sort of common things that happen to it when it gets traumatized. And so when we image, we look for those common fractures, and then we start to look for the associated nerve image or the brain trauma. One thing that's important to remember is that the brain swells over time. So oftentimes patients will be sort of lucid for a while, but the brain has like max edema at 11 days. So patients will go along and go home and sleep it off, and then they might not wake up because the brain goes into that edema phase. So the brain is really actually pretty dynamic, and so you have to look at it with that in mind, and also diagnose it with those, separate functions.
Well, does the brain have a tendency to shrink in size if it becomes injured, or maybe not enough for lesion, but perhaps bruised? The brain gets bruised. I would imagine that someone that's close to a 5-inch cannon there going off all the time, that concussion hitting your head could bruise the brain. I mean, is there any way to tell if the brain was bruised or shrunk some?
Yeah, that's exactly right. Like if you keep stepping on a rock on your foot, you're going to get a bruise on your foot, and it's going to swell up. It's micro trauma. So the brain's the same way. It's going to swell. The problem with the brain is that it's inside a little box, so it's almost like an eggshell with an egg inside. So there's not much room when you're young for the brain to swell. So in young people, when they get those micro traumas like that, the brain can swell, and then you don't get very good perfusion, like Bill was talking about, anoxia, and you can actually have brain death just based on swelling. When you're older, as you go through life, the brain starts to shrink slowly, and so I even have seen cases where older patients, 80, 90-year-olds have huge tumors in the brain that suck up that extra space that's kind of residual there now when they're older, and they don't even have any symptoms because there's so much room inside the bony vault. So it depends on how old you are when you have it, how much trauma you have, what type of trauma, and a lot of factors involved.
Good question, Dr. Bash. Have you ever diagnosed a case of Huntington's disease?
No, I haven't. I've read teaching files, but I haven't done that, no.
Okay. That's a bad brain disease, people.
You did bring up an interesting point there, peripherally, about identifying what's being claimed. The manual, again, here makes it very clear that these claims must be read sympathetically. Right? So it specifically provides that if somebody puts in a claim for head injury or concussion, right, they must accept that as a claim for residuals of a TBI. And conversely, if a veteran claims things like combat injuries, assault, automobile accident, a fall, or any other injuries or events that raise the issue of TBI, if there was an injury to the head. Okay? So if a veteran specifies that he was in some kind of an accident or an assault or combat injury that was traumatic to the head, then whether the veteran does or doesn't specify a claim for TBI is not relevant. The VA is to construe that as a TBI claim. And then again, conversely, if they file the claim for the TBI, the duty on VA is to identify any complications, like were there there's IED or something, where there are burns, muscle injuries, orthopedic injuries, amputations, in addition to the brain injury. So it works both ways in favor of the veteran. We can only hope that it will be sympathetically read and understood.
Hey Bill, how does this work? I see a lot of patients come with
same question.
With symptoms. They'll come with like headache. They'll come with like tinnitus. They'll come with dizziness and memory loss. So there's not much of a. It's hard for the rater to maybe put those together as a TBI. But is there any kind of thing in the manual that tries to help them do that or provide integration?
No, only the section I was just referring to. You find it at. I'm going to read off the numbers. Make a note or you can search it on the website. M21-1, 3, Roman numeral 4, number 4, N, 2, E. And that makes clear that if there was an injury to the head, then accept it as a TBI claim. And if they're claiming a TBI, be sure to explore the burns and injuries and amputations and all the other things for all disabling chronic residuals of the event, not just the head trauma. So the rules are on our side.
Hey, Bill, how does that work on historical claims? Like, so say, for example, before the TBI criteria came out, the veteran had a head injury and he was treated for residual concussion. Is the criteria...
Prior to 2008, Diagnostic Code 8045 had no evaluation other than 10%. Period.
Right.
Okay? If the record indicated that there were complications like paralysis or skull loss or vision or hearing, they were separately evaluated. I should say could be separately evaluated. But the TBI itself, or brain disease due to trauma, as it used to be called, is just 10%. That's all there was. Mm-hmm. Now, since the rule changed in 2008, anyone who claimed an increase in evaluation from 2008 to 2009, the effective date would go back to 2008. I think that was October 23rd, if I remember. And as long as you got your claim in within a year of the rule change, the effective date is the date of the rule change, October 2008. If you miss that 1 year, but if your symptoms in 2008 warranted a higher evaluation, then your current evaluation would have a 1 year retroactive effective date from the date of claim. Well, that sounded a little complicated, didn't it? But that's what's called liberalizing rule 3.114 in the regulations. And basically, when the rule changed, you were entitled to the higher evaluation. Get your claim in the first year, it goes back to the rule change. Miss the deadline, it goes back 1 year.
You learn something new every day, folks. Go ahead, Dr. Bass.
Yep. So let's go back to the symptoms. So, a lot of patients have symptoms. So all the patients out there, if you have some cluster of symptoms you think might be a TBI, don't go see your family practitioner or your local PA. You want to go find a neurologist or somebody who knows about the brain, because if you go to the VA with a TBI diagnosis, you have a lot better chance of getting a correct rating if you go there with a cluster of symptoms that the VA can't, sink their teeth into.
So a veteran, if he has those, symptoms, he thinks might be a TBI or something like that, then he should go see a neurologist or possibly even a psychiatrist. Wouldn't that work?
Mm-hmm. Mm-hmm. Yeah. That could lead to the neurocognitive testing. And your attending physician can make the referral. Yeah.
Yes.
A lot of these patients have mental deficits, so they might not be able to navigate that, but they have to try and get themselves to a specialist.
It's just a matter of getting the proper documents to back up. I would imagine you're going to a veteran would have to seek out the aid of a psychiatrist or a neurologist or someone like that, either within the VA or out of the VA, in order to get the necessary documents to help prove up their case.
Yes, yes. And I would say that if the veteran is intending to make the claim, you can certainly file an intent to file, ITF. And you can file a document with VA. They send you a form. And they say, I intend to file a claim for TBI. That anchors your effective date, and then you can develop your evidence and submit it. And that can help move it along. And at the same time, preserve the earliest possible effective date.
Yes, Dr. Bashke, I can't emphasize enough about the diagnosis. You know, if you take your car into the Volkswagen versus a Chevrolet, they're going to treat it differently. The VA is going to rate it differently. So our first patient had that diagnosis of amnesia, and that was the wrong diagnosis.
Yeah.
Now again in the category TBI. So the patients have to really kind of make sure that their doctor gives them a concrete diagnosis, because sometimes when the doctor's confused, they won't give you a diagnosis, and then you don't make any progress in treatment or for VA purposes rating.
Yeah, and to the spouse or the significant other out there, if you're observing symptoms and they don't seem to add up or make sense, you might have to hold that person's hand and guide them to get the right help.
I think that's bottom line, Bill. I mean, you're saying too many things that just don't make sense, and I don't see any other choice but to get to a specialist, a medical specialist of some sort.
Yep.
Because as a rule, most things, I know they say a lot of times, well, it's undiagnosable, but I for one just don't buy that story. It just tells me that they haven't properly diagnosed it, and that's just a cop out.
Yeah, the way I deal with that is if I can't diagnose it, I figure I'm not smart enough, or I haven't read enough, or I haven't got them to the right person yet, you know?
Yeah. That's why I see things in records and I say, hey, Dr. Bash. Am I good for your what? We got time for just one example. I was looking through a record, and the veteran was trying to prove that his multiple sclerosis started in service. He was totally convinced that it was, because the symptoms that he had episodically after service reminded him of the symptoms he had in service. And so when he was finally diagnosed with MS, which was a long time after service, he was totally convinced that it started in service. Well, VA had examined him 2-3 times, and all the doctors were lining up and saying, no, there were no symptoms of MS present in service. So I took a look through his record, and I did some studying and imaging, and it showed, certain abnormalities in certain locations of the brain. So I just looked it up on the line, and I realized, that portion of the brain affects hearing. So I looked through his treatment records, and I see at one point in time the veteran complained that his hearing seemed odd. It sounds like my head is in a bucket. Okay? Well, what explains that? Who knows? They didn't know. But then I noticed that his hearing tests, he had sequential hearing tests in service, and they were all over the map. So we suggested that these lesions on the brain are consistent with those in MS cases. They've been used to diagnose MS in this case. So the veteran has MS with lesions in this area. This area affects hearing, and here are abnormalities of hearing in service records consistent with MS. Board of Veterans Appeals in that case decided to send it to a university, and the department head, the head of neurology in that university, and came back and said, no, it's related to his sinus trouble. Well, I got a hold of Dr. Bash, and what I stressed with Dr. Bash was, look, if it's infection, then we would predict a cross-the-board loss. Low, medium, high frequencies across the board are all going to go down during the infection. And then when it clears up, those frequencies will all recover. In this case, it wasn't like that. In fact, his hearing was worse after infection went away. And it wasn't across the board. It was at specific frequencies. If you could picture two hands playing a piano, pushing on the keys, okay, and then put that on your hearing test and see the frequencies going up and down at different frequencies, different ears, and different times. Now, what can explain that? Other than relapsing, remitting MS that's affecting different functions at different times in that recognizable pattern. So Dr. Bash, he agreed with me, little old Bill. He explained it to the BVA, and BVA accepted Dr. Bash's opinion over the department head of neurology of a major university.
Now that's unusual, but Dr. Bash is very thorough in his IMOs, his statement. So with that explanation, I don't see how they could do anything but agree with it.
Hey, Bill, in that case, do we have lesions in the brainstem? We had some lesions in the brainstem, I think, too, didn't we? Some lesions in the midbrain.
Oh my! I have to go back a long time.
Yeah. That would be a real kicker. That'd be a real kicker because the place in the brain that shows up that affects hearing would be right in the midbrain. So if we probably did have midbrain lesions, and I went through the whole explanation. And so that's what really rolled them over probably. So, thank you all for listening. That ends the show. Now I'm going to zoom out.